Welcome back to Neurovascular Nugget, everyone. Today, Salma and I are dissecting a really impactful study that sheds light on managing one of the most critical neurovascular emergencies, poor grade aneurysmal subarachnoid hemorrhage, or aSAH.
It's a topic that's always at the forefront of our minds, Professor. Patients with poor grade aSAH are incredibly challenging to manage, and any new data that can guide our treatment strategies is invaluable. I'm really keen to dive into the comparison between surgical clipping, or SC, and endovascular coiling, EC, for these patients.
Absolutely, Salma. This study in particular looked at 1326 patients with poor grade aSAH, specifically those with a WFNS grade of 3 to 5. That's already a tough cohort, meaning they're presenting with significant neurological deficits. They split them into two groups, those who underwent SC and those who had EC.
And the initial numbers were 847 for SC and 479 for EC, which is a fairly good sample size to begin with. But I noticed they used propensity score matching, PSM, which is excellent for trying to balance out the groups and reduce selection bias, right?
Precisely. PSM is crucial here. Without it, you might be comparing apples and oranges, given that patient selection for SC versus EC can be influenced by many factors: patient age, aneurysm morphology, comorbidities, even the treating physician's preference or institutional expertise. After PSM, they had matched cohorts of 316 patients each, which makes the comparison much more robust.
So let's get straight to the clinical outcomes. What did they find regarding favorable versus unfavorable outcomes, Professor?
Well, this is where it gets really interesting. Before PSM, unfavorable clinical outcomes, which they defined as an MRS score of 3 to 6, meaning moderate disability to death, were 72% for the SC group and 66.2% for the EC group. So, even initially, EC seemed to fare a bit better.
And after PSM, did that difference hold up?
It did, and actually the difference became even more statistically significant. After PSM, unfavorable outcomes were 70.6% for SC versus 63.3% for EC. That's a pretty substantial difference of over 7 percentage points. It truly suggests that EC might offer a better chance at a more favorable clinical outcome for these patients.
That's a huge takeaway for our clinical practice. If we can shift patients from an unfavorable outcome category to a more favorable one, that's incredibly meaningful. But what about mortality? Sometimes better outcomes come at the cost of higher immediate risks, or vice versa.
Excellent point, Salma, and that's precisely what they looked at with in-hospital mortality. Before PSM, mortality was actually higher for EC at 16.1% compared to SC at 10.5%. This might have initially led some to believe SC was safer in terms of immediate survival.
Which could be a misleading initial finding if you don't account for confounding factors.
Exactly. But once they applied PSM, that difference vanished. After PSM, in-hospital mortality was 12.7% for EC and 10.4% for SC, and the difference was no longer statistically significant. This tells us that while EC offers better clinical outcomes, it doesn't necessarily carry a significantly higher immediate mortality risk than SC once patient characteristics are balanced.
That's a critical nuance, Professor. It means we might be able to achieve better functional outcomes without compromising on immediate survival. It really strengthens the case for considering EC first.
It certainly does. Now, let's dig a bit deeper into what predicts an unfavorable outcome. This part is crucial for patient selection and counseling. The study identified several common predictors in both groups: WFNS grade V, which is the worst neurological grade, age older than 70 years, and Fisher CT grade 4, which indicates a large amount of intracerebral or intraventricular blood.
Those seem pretty intuitive. The sicker the patient, the older they are, and the more blood in the brain, the worse the prognosis. That aligns with what we generally see.
Indeed. But then they identified some specific predictors that were unique to each treatment group. For the SC group, WFNS grade 5 and Fisher CT grade 3 were associated with unfavorable outcomes. This means even a slightly less severe neurological grade or less widespread bleeding still posed a significant risk for patients undergoing surgical clipping.
So, if a patient is WFNS grade 5 or Fisher CT grade 3 and we're leaning towards SC, we should be particularly cautious and perhaps even reconsider given these findings?
That's exactly the implication. It suggests that these specific patient profiles might be more vulnerable to the stresses of open surgery. Conversely, for the EC group, ages in the 50s and 60s were associated with unfavorable outcomes. This is interesting because we often think of EC as less invasive, but perhaps these patients in their prime working years have different physiological reserves or comorbidities that make them uniquely susceptible to complications in the EC setting. Or maybe they just have higher expectations for recovery.
It's a bit counterintuitive for the EC group, isn't it? You'd think that the younger, older patients, if that makes sense, would do better. It makes me wonder if there's something about the aneurysm characteristics that might push patients in their 50s and 60s towards EC, but those characteristics themselves are prognostic for worse outcomes, regardless of the treatment. Or perhaps they have less physiological reserve than younger patients but haven't yet accumulated the severe comorbidities of the over 70 crowd.
That's a very insightful point, Salma. It could be subtle differences in the pathology or resilience. It underscores the complexity of these cases and why individualized treatment plans are so vital. But the overarching conclusion from the study is clear. EC was associated with significantly more favorable clinical outcomes than SC in poor-grade aSAH, without significant differences in in-hospital mortality after careful matching.
And the benefit of EC was particularly notable in patients with WFNS grade 5 and Fisher CT grade 3, which is exactly where SC showed specific predictors for unfavorable outcomes. It feels like a convergence of evidence.
Precisely. This brings us to the very important implications for clinical practice. First, there's a strong suggestion for a treatment strategy shift. These findings suggest that EC may be preferred over SC for poor-grade aSAH due to better clinical outcomes at discharge. This could lead to a significant shift in treatment protocols, especially for high-risk cases.
So, we're talking about making EC the first line consideration, essentially. That's a big change from perhaps a more neutral stance or a case by case debate that often happens in conferences.
Indeed, and that leads directly into patient selection. Clinicians might now consider WFNS grade 5 and Fisher CT grade 3 as indicators for specifically opting for EC over SC. Understanding these specific predictors helps us tailor treatment plans to individual patient profiles, potentially improving overall outcomes.
That's really actionable. It gives us clear markers to guide our decision making. What about age considerations? You mentioned older age over 70 was a common predictor of unfavorable outcomes.
Yes, absolutely. With older age being a significant predictor, it means that for elderly patients, regardless of whether they undergo EC or SC, more careful consideration and possibly more aggressive management of associated comorbidities and potential complications might be necessary. Their overall physiological reserve is lower, so every decision carries more weight.
It's a reminder that treatment isn't just about the aneurysm itself, but the whole patient. And then, Professor, what about the institutional implications? Not all centers are equally equipped for both modalities.
Excellent point. This study really highlights the need for high-volume cerebrovascular centers, which are typically equipped to perform both SC and EC, to allocate more resources and training towards enhancing their EC capabilities. If EC is demonstrating superior outcomes, then it's incumbent upon these centers to ensure they can offer it optimally and widely.
It makes sense. We need to be able to provide the best possible care, and if the evidence points to EC, then we need the infrastructure and expertise to back that up.
Precisely. And finally, these robust results might very well influence revisions of existing guidelines from major bodies like the American Heart Association, American Stroke Association, and the European Stroke Organization. These guidelines are the backbone of our clinical practice, and if the data shows the potential superiority of EC in poor-grade aSAH cases, then it needs to be reflected.
That would be a huge step. Having these findings incorporated into official guidelines would solidify the shift in practice and provide clear recommendations for clinicians worldwide. It really feels like this study, Neurovascular Nugget 22, as we're calling it, is a game changer for poor grade aSAH.
I agree, Salma. It reinforces what many of us have suspected, but provides the much-needed robust data to support a preference for endovascular coiling in these particularly challenging patients, especially those with WFNS grade 5 and Fisher CT grade 3. It's about giving our patients the best possible chance at recovery.
It's truly exciting to see research directly translating into better patient care. Thank you for breaking this down so clearly, Professor.
My pleasure, Salma. And to all our listeners, thank you for joining us on this deep dive into Neurovascular Nugget 22. Stay curious, stay informed, and we'll catch you next time with more insights into the world of neurovascular medicine.